I'm going to ask the question that most people wouldn't want to ask, which is, you're young, you've been married a couple of years, you're trying to have a baby, this happens to you. Should you only be freezing your embryos? You know the question is
I know where
coming.
you're going. Yeah, it's interesting.
But someone's got to ask it.
Yeah, ask it.
Okay. Or should you also advise a young woman to also, now that it's viable today, to also freeze her eggs, because you don't know what's going to happen in the future. And I don't mean to say this in a negative way. I don't just mean you might divorce. I mean, who knows what happens? Nobody knows what life will bring tomorrow. And what if 10 years from now, you're remarried, you're widowed, remarried, whatever it is, now you would have an opportunity to also have your frozen eggs, as well as frozen embryos.
So I think the practice, from what I understand, is offering patients both now at centers where there's the opportunity. Not every center can freeze eggs quite as well as they do embryos. We have a longer track record with embryos. But egg cryopreservation, egg freezing, became not experimental a few years ago because the freeze-thaw technique got good enough that it's considered as good as the embryo cryopreservation or freezing. That being said, it is a moving target, and recently I've heard from our people that they offer everybody both. They don't tell everybody to do both, but they offer people both. And then it's kind of up to the woman and her partner if she has one. Some women also are not partnering. So our partner, they're going to a sperm bank. And so for those women, it makes a lot of sense to do both because they want to kind of hedge their bets. They want the embryos, but they may also want to be able to partner with somebody else's sperm someday if they might want a male partner someday.
And it might be a tough question to even be presented with when you go in with your husband, but I figured I should at least bring it up so that it...
Oh, I think it's a great question. I
so
think
that at least you
it's
have...
out there.
It's out there.
I think the reality is, we know, what are the stats? 50% of marriages end in divorce now. And, I don't know that I don't have data on this, and we are studying it, but does breast cancer increase or decrease that? I don't think we know, but it certainly challenges a young couple. And so I think, if people are doing this to preserve their fertility and they want to be as kind of careful and as low risk as possible, at least in terms of hedging the bets that they're going to be able to have a biologic child, ideally with the partner with whom they are with in the future, or on their own. People certainly do it on their own. I think it's reasonable to do both. But it's a really personal decision. And I've seen all kinds of things. And patients bring it up to me, and sometimes I bring it up to them if it's solicited. But it is a tricky conversation with the two of them.
I figured I just have to throw it out there. So at least they have the thought process, because it's not something you would have the tendency to have a thought process about if you're early on in a marriage and you think nothing's ever going to change in life, but sometimes it does.
Yep, and I don't envy the fertility doctors who do have to have these conversations, and they've got to also have the tricky conversations of what if something happens to someone? What if somebody dies? What's going to happen to those embryos? So they do have those conversations because there's all kinds of legal rules around that to try and make sure that embryos are treated properly in the, if something should happen to someone, and how long do you store them? There's all kinds of logistical issues and ethical issues there.
But that need to be looked at, along with going to the oncologist and finding out what treatment you're going to be taking. Another thing that young women then, as they go through this cancer treatment, are dealing with hot flashes. I mean, this is something that you don't usually deal with until decades later. And how long do they last?
It's very variable. For some people, they're very short term. Even if they don't start having menses again, the medications, the tamoxifen, can cause hot flashes, even in a woman who's premenopausal or still having her periods. So it's very variable why they are having hot flashes. And then it's also variable in people. People are just different. And I don't, there's lots of research looking at this. We don't have the answers yet, but some people have a pretty mild menopause, whether it's medically induced or natural, and some people are miserable and have hot flashes for a decade or more. And we don't really know. The good news is we do have some medications and some kind of behavioral things that can help. Acupuncture, we think, helps. I mean, there's lots of things to try. Some of the newer medications that actually treat depression at low doses can treat hot flashes, and some other medications. So we use those in some patients for whom the hot flashes are disrupting sleep and making them miserable. It is an important side effect. Some patients, though, see it as their power surge. and they'll look at me and say, and I try and help them, obviously I don't say that first because they might want to hit me if they're having a hot flash and they're uncomfortable. But I've had patients say to me, you know what, that makes me feel like the treatments and the anti-hormonal things are going to prevent my breast cancer from coming back.
Shows me it's working.
It shows me it's working. Another patient's optimistic. Another patient said, I view it as my own private summer.
So let me ask you another, now that we're talking about hot flashes, where does the oncology field come down now on HRT? And what role does taking HRT in order to reduce hot flashes in women, what kind of an impact does that have on your risk of getting breast cancer?
So the HRT role and where we come down kind of depends on the patient population we're talking about. So in a general patient population, we now know that HRT does not prevent heart disease. Okay. When they did that, it does not help. And that's what we were giving it for a long time.
Absolutely.
Until the Women's Health Initiative showed that it didn't actually improve how women did, and it caused breast cancer. And so we all said, okay, let's pull that back, which is it's just hard for women because they're having side effects and things like that.
But then that was questioned a little bit.
Yeah, so there's all kinds of questions, and no research is perfect. But it was pretty definitive that we shouldn't be wholesale putting women on HRT unless they really need it. Before we gave it whether they needed it or not for symptoms. And so now I think the general medical practice for your average risk woman is to, if she needs HRT for symptom management, to try and do it short term, to get her through and reduce, and then get to the lowest doses possible and then wean her. That is, I think, the general kind of gestalt of how we try and manage it, because we know it increases the risk of breast cancer. In a woman who's high risk for breast cancer, or certainly in a woman who's already had breast cancer, we generally try to avoid it and treat with things that can help some of the symptoms, but they're not as good as replacing estrogen. And so if we do need to replace estrogen, even in a breast cancer survivor, we do it very judiciously, and we weigh kind of, how high risk of cancer did she have, how miserable is she, and we try and give the least amount for the shortest time possible. But it's tricky and very tailored, and we try to not, a lot of our principle behind treatment of breast cancer is lowering hormones. Yeah. And so giving them back sometimes is tricky. We do it in certain situations, like if someone's on tamoxifen, we feel a little better about it because that presumably would block the estrogen at the breast cancer cells, if there were any out there, but wouldn't take away the relief of symptoms. Yeah. So it's complicated, and I will tell you there isn't a whole lot of consensus around this. So even experts disagree about the safety of giving people back hormones when they've had a cancer. For the patients who haven't had a cancer, it's a little easier. You do it for a short course if you can, but there are women who can't get off. And then you say, well, she's not that high a risk and she'd be miserable, so you take your risks.
That's right. And a lot of women say, I don't have it in my family, so therefore I'm not at risk, so therefore I can take it.
Yeah, they're still at risk.
That's rationalization,
that's
though,
rationalization, but some risks are worth taking.
But a somewhat small percentage of women who are diagnosed with breast cancer actually have it in a family history. And yet I hear from women all the time who say, oh, I hope you're doing better. Thank God I don't have to worry about it because it's not in my family.
That's a false reassurance.
And I used to be one of those women. Yeah. I was living under that myth.
Yeah, I mean, anybody with breast is at risk. Family history increases that risk, but you're still at risk. And most women do not have a strong family history of breast cancer, and they get breast cancer. And so that is the fact. So everybody's at risk, and there are things that increase the risk on a population basis. For any given woman, though, it's hard to pick out who's going to get the cancer. We can say in 100 patients that 8 in a lifetime, 1 in 8, right? So 12 in a lifetime of 100 patients will get breast cancer. But we have a hard time picking which one, unless they have a really high-risk family. Otherwise, it's all kind of, small incremental increases for each of our risk factors. But again, targeting which woman will get it has been very, very difficult. And so we're left with the do what you can to reduce it, don't add on things that you don't need that increase the risk. At the same time, if you're miserable from hot flashes, then a little bit of hormones probably makes sense for you as long as you're being followed. And if you get a breast cancer during that time, they're often very treatable. So it's not the end of the world, and you shouldn't say, oh, I should never have done that. If you needed it, you had to do it. I mean, I liken it to, I drive to work every day, all right? And we all get in the car. And many of us drive, right, or sit in cars, and we're all at risk for a traffic accident. Hundreds of thousands of people die in traffic accidents in the US alone every year. And yet we get in our cars and we're careful and we put our seatbelts on, but we take those risks because they're part of living, they're part of playing the game. And I think that sometimes we need medically to say, all right, I don't want to do anything foolish, but sometimes if you need something to make yourself feel better in the short term and you're being monitored, I think it's okay.
Are there certain things, though, here in America, with our American food system and the increase in obesity, which as I understand it, hormones are kind of stored in all that excess body fat, is that part of the reason why it just seems like we're seeing more women presenting with breast cancer?
So I think that the obesity epidemic is absolutely contributing to a certain proportion of breast cancers being diagnosed. And we may see more increases over time if we don't get a handle on this. So our US population really needs to focus. Again, hard to target an individual, and not everybody who's heavy is going to get breast cancer. On the flip side, my clinic is full of thin people, and they look at me and say, I was doing everything right. So, again, it's population-based, but still, it's averages. But I think as a population, we need to be careful, and we need to start thinking more preventatively, not just about cancer, but heart disease and other ills that are associated with obesity and insulin insensitivity, because that's part of what is diabetes. Obesity can lead to type 2 diabetes, which we think all of that has to do with the development of certain cancers like colon cancer, breast cancer, and in men, prostate cancer. And so, our whole society would do better for, cutting down a little bit. Easier said than done, but we need to start thinking about it. And I think there are movements to do that. It's much harder.
I keep seeing, though, in all of the research now, insulin spiking, and inflammation, and also the effect that stress can have on the body in terms of inflammation. Is that possibly also contributing to this increase in cancer in this country? Because certainly we are a fast-paced, stressed out bunch of people.
Yeah, so the stress, so definitely the obesity is contributing. Definitely we think there's the association, one of the mechanisms may be the insulin insensitivity. Stress is harder to measure, and the studies have been much less clear. Stress is it really stressful, or is it perceived stress? And one person may see a very busy day as an easy day, and one person may see that as the most stressful day they ever had. And so how you get a handle on that, I think for anybody, we do know, for anybody who's survived breast cancer or who's living with metastatic disease, for women in that setting at least, we don't know that stress increases the chance of a cancer coming back or shortens a person's life. And so there was a lot of hype a decade or so ago that if you were stressed or if you didn't join a support group, somehow you were compromising your chances at survival. And those data have been debunked. And so, women who don't want to join support groups, who don't get nurturing out of that, shouldn't feel that they're just serving themselves from a survival standpoint and force themselves to go to a support group if that's not their thing. That, there was this whole kind of backlash where women felt guilty because they didn't do enough to control their stress. That should not be the case. What we want people to do, though, is to have a good life. We want people to exercise, take care of themselves. Those are the things that have been associated with people doing better after breast cancer. So people who are physically active and people who don't gain a lot of weight after a diagnosis of breast cancer. That's been associated with people doing better from a breast cancer survival standpoint as well as from an overall survival standpoint. So that's the key message. Take care, and those are also de-stressors. So if you're really stressed, it's hard to exercise, it's hard to eat right. And so if stress drives bad behaviors or not optimal behaviors, then yes, people need to lower their stress so that they can do the right thing for themselves and take care of themselves.